Hello, everybody. Welcome to Samaritan's Purse International Health Forum. I'm Dr. Lance Plyler, your host. Just delighted to have you all join us today from all around the world. If you'll look to the right of your chat box, you'll see that I've already put in my name, Lance Plyler, and my location, and just encourage you to do the same so that we know exactly where you're listening in from. You know, today I just want to reassure our listening audience, those of you that are watching, just with regard to the pandemic, you know, God is still in control. Right now, Samaritan's Purse is alive and well and serving all around the world through our World Medical Mission partner hospitals, our surgical subspecialty teams that are reaching out to our partner hospitals as well, and our DART team. Our DART team is very busy right now, deploying in such places as Mississippi in the United States, where they're just overwhelmed with COVID patients, and they're doing an excellent job of providing care for patients stricken with COVID there. We're also deployed right now in Lacaille, Haiti, after another 7.2 earthquake hit in Lacaille, and our emergency field hospital is set up there. So we just really want to express our appreciation to you, our volunteers, and those that have been serving through the auspices of Samaritan's Purse to provide medical care, all for the sake of the gospel. And I just want to encourage you guys today as we listen in. Again, just remind you to utilize that chat box to sign in, and then we'll also be using that at the end for dedicated Q&A. Before we get started and I introduce our speaker today, I just want to open up in a word of prayer. Dear Heavenly Father, we just come to you today. We just pray on behalf of your name, Lord. There's so many things going on in the world right now, things that seem overwhelming, like the pandemic or earthquakes, pestilence, Lord. But we know that, Lord, this is prophecy. This is in your word, and we trust you, God. And we just utilize this as opportunities for open doors to reach others with medicine, all for the sake of the gospel. Lord, I just thank you for Dr. Steve Martin and pray that you speak through him today. And it's in Jesus' name we pray. Amen. So today, it's really my distinct honor to introduce a good friend of mine and colleague, Dr. Steve Martin. Dr. Martin will be presenting today Pediatric Hematology Oncology, Challenges and Capabilities within the Mission Hospital Setting. Steve is a very qualified speaker. He's a pediatric hematologist, oncologist. He's on faculty with the University of South Carolina School of Medicine, located in Greenville, South Carolina. And that's actually where he attended medical school when he conducted his residency there in South Carolina. Thereafter, he completed his fellowship at Riley Hospital for Children in Indianapolis, Indiana, where he did research that was primarily focused on improving treatment outcomes in sub-Saharan Africa. After his fellowship, Dr. Martin served as the medical director for Texas Children's Hospital Global Hope Program in Malawi, where I believe he served for over 4 years. So he comes with a lot of developing world experience. So without further ado, Dr. Martin, it's a real honor to have you speak to us today. Thank you for coming.
Well, thank you for having me, Lance. Thank you, everyone. It is a privilege to be here today, and just hopeful and prayerful that the skills that God has given me would be able to contribute to the work that Samaritan's Purse World Medical Mission is doing. And really, you know, it's a smaller, if I think about pediatric oncology, it's a smaller piece of the puzzle, a piece of the pie, but it is a great joy. My hope is that this would shed a little bit of light on the pediatric oncology and hematology issues in limited resource settings, figure out how we can pitch in for those who are on the ground, and really be faithful to what God has given us more than anything. So I just appreciate the chance to be together and to give this talk. So without further ado, let me share my screen. Hold on just a second. All right. Everybody see that okay? Okay. First of all, just no disclosures, conflicts of interest at all to share with you. Just a little bit about me. I have not done this journey even from the onset of medical school by myself. I went had a change of calling and went to medical school as a husband and a dad, and we ventured through many years together. And as Southerners, we learned how to live in the snow in Indiana, which was actually one of the best things for us we could have had. But just some great seasons of life of God's faithfulness through many places. So for us, really, it's given us a bigger view of the world. This is my favorite picture of our 3 children. They're literally straddling the Malawi-Zambia border road crossing. So for us, it has been a wonderful gift to see a bigger part of the world, to be involved. But I realize today, in all humility, that I'm talking to a lot of people who have been on the ground longer than I ever will be, and have more experience and made more sacrifices than I ever will. So I say all this humbly. Number one, I'm not an expert. And number two, I just just say this all out of appreciation for those who are on the field, boots on the ground, and faithful to the work God has given them. So however this can contribute, I hope and pray it will. So really what I want to think about the goals of the seminar, one, give you just a kind of landscape of what childhood cancer and blood disorders look like in low and middle income countries. Really much of that being the countries and places where hospitals are being supported and served through SP and World Medical Mission. Kind of make a plausible case for why we need to advance care in this area. Give some experience and lessons learned based on our time in Kenya and Malawi as well, just understanding the granular details of the challenges of pediatric cancer and blood disorder care there. And really the traction I want to gain off of this talk, knowing that I'm talking to a lot of people that are on the ground, that are covering large areas of patient populations, geographies. Really, how can peds hemonc care be advanced in the mission field setting? Really assessing current capabilities and really setting some short and long-term goals. So that's kind of what I want to get in. That's what I want to get through during this talk today. If I think about the disparities of care, and this is not a surprise to you, to all of you, but we have the privilege of having the resources to identify, treat, and cure children with cancer in the U.S. and in high-income countries. You get diagnosed with cancer here, and you have generally over 80% survival rate. That's flipped on its head in sub-Saharan Africa. And right now, over 80% of all children diagnosed with cancer in sub-Saharan Africa will die. And those are the ones that even make it to the hospital. So that's speaking to the magnitude of the disparity of care. For those who are on the ground, you know this already, you feel this. 80% of cancer occurs in low to middle income countries. So it's not just that the death rate is higher, but you're actually seeing proportionally more patients than a high income country would. As far as types of cancers, just to give you a quick idea, generally acute leukemia, if you're listening and taking notes, that is the most common type of childhood cancer we see. Certainly in sub-Saharan Africa, in the malaria zone, we see more cases we see a lot of Burkitt lymphoma patients. But generally, if you're talking globally, leukemia is still our #1 culprit. So part of our research in Kenya focused on leukemia. And so that's what I'm going to be talking about a lot today. And not only for an oncology standpoint, but from a hematologic standpoint, sickle cell disease is really a rampant problem, particularly sub-Saharan Africa, Southeast Asia, and surprisingly in Central America, it's not uncommon as well. So as you remember from your medical textbooks, this is something that it's a generic aberration of the coding for developing a red blood cell. Instead of making healthy, plump red blood cells that look like Krispy Kreme donuts, you have sickle cells that are not malleable. They clog up vasculature, and they can create a whole host of problems. And really, unfortunately, the burden of sickle cell disease, it has been borne through sub-Saharan Africa and to some degree as well, Southeast Asia. Part of this just developed for your history lesson. People would pass down a genetic trait of sickle cell, but not the actual disease, which actually had protective effects against malaria. And so unfortunately, that being a recessive, sickle cell being a recessive disease, two parents with sickle cell trait would produce a child with sickle cell disease. You see it much more in Southern Africa and Southeast Asia, but unfortunately, sickle cell disease is not protective of malaria. Only sickle cell trait is. So there's a multitude of complications, and really beginning around 9 to 12 months old is when you start to see infants and children with dactylitis, infections, acute infections, and essentially it's a chronic disease if you get to if you even make it to an older age. Most children, as I'm going to show you, most children in sub-Saharan Africa don't even make it out of childhood with sickle cell disease. And again, the distribution is in these limited resource settings. If you look at the map as far as what it would look like from a distribution standpoint, that's the burden of sickle cell disease in sub-Saharan Africa and Asia compared to what you would see in the US, South America, or even Europe. So again, we have better outcomes in the US with sickle cell disease, and my hope is that we can improve that in areas where resource settings are limited. So a little bit about what I have been so privileged to have been doing and been involved with at Indiana University through my fellowship, and then also through my time with Texas Children's Hospital in Malawi. I was involved with Moi Teaching Hospital in Eldoret, Kenya. That is in the western part of Kenya, a couple hours from the Uganda border. Around 2 million people in Eldoret proper. It is where all the Kenyan marathoners are from, or just about. So it would not be uncommon to see Boston marathons, Tokyo marathon champions running through the neighborhoods right behind where I used to work. But importantly, it serves a population of Western Kenya, Northern Kenya, even into Southern Sudan, of about 16 to 18 million. So that is a huge burden for one hospital. And what really came about through the research, through our time on the ground there, was really figuring out what were the barriers to improved outcomes. And I'll talk about the medical barriers, and also the socioeconomic barriers that we experience there. And again, for those who are on the ground, you see this every day. This is intuitive to you at this point. From a medical side, really the kids came too late and too sick. Most of the patients who had been symptomatic for more than 3 months had died. Even those who came between 1 and 3 months, the mortality rate was very high. What you would find often was these families would first go to local healers. They would go to local clinics, and they would be seen there locally several times before they were able to be sent to the referral hospital. And through that, unfortunately, cancer eats away at the body. And even during our time in Malawi, our research showed that 80% of our new cancer patients showed up moderately to severely malnourished. And that made it hard for us to treat them. That made it hard for us to treat them. They were too sick and too malnourished to withstand chemotherapy and even get them stabilized. The other problem that we had too was just the need for accurate diagnostics. Malaria produces cytopenias, low white counts, low hemoglobin, low platelets. but so does acute leukemia. And so what we had found was actually many of our patients actually got misdiagnosed as having malaria when in fact they had acute leukemia. And even looking at the slides from the untrained eye, that's plausible. So really the need to have accurate diagnostics, to have good pathology in place, really, because without an accurate diagnosis, you're never going to be able to treat the patient. And then also too, really learning the importance of treatment that is in line, appropriate with the given resources of the hospital. What we had figured out was trying to do oncology care based on treatments and protocols that we commonly use in the US and in Western Europe. The patients were too sick. The resources were too limited to be able to successfully treat them. So even in the first month, which we would call induction, the first month we would see when we had these, when we treated them on these higher protocols, we actually were seeing a jump in deaths during that first month because the patients weren't able to handle treatment. So again, we had to, during our time in Kenya, we had to reconsider what we were doing because it had to be appropriate for the setting it was given in. So we had to change our induction regimens. We had to make them appropriate for the resources and appropriate for the patient's condition and diagnosis. And again, doing so, we were able to improve outcomes for leukemia as well. So if I think about the medical barriers to successful care, the kids came too progressed with disease, they came too malnourished. Really within the hospital settings, there was limited availability of antibiotics, chemotherapy, and blood products as well. That was a rate limiting step for many of our treatments there. And again, chemotherapy and treatment regimens in high income countries do not translate into those in low income settings. So from the medical side, then we think about the socioeconomic side. Really, what are the barriers? And it is financial often. Most families did not have any sort of health insurance through the government. During treatment, 70% families had no regular income at all. And again, family income in Kenya had decreased to approximately $1.50 a day in treatment because one parent had to be in the hospital and the resources were limited. And then the family income decreased as well. So what that resulted in was treatment abandonment. If it is between staying in the hospital with a sick child or tending to your farm and tending to the other 5 children that you have, unfortunately, families have to make hard choices. And again, if you look on the right, that was the cost for treating. This was actually on the wall in Eldoret in the hospital originally. That was the cost in Kenyan shillings that families would have to come up with for treating their child with certain malignancies. So a leukemia patient would cost over $4,000, and you can imagine how exorbitant that would seem for families. So again, we had seen our cases grow in Kenya. Part of that was from some of the outreach projects that we had done to reach out to the district hospitals, the outlying areas. And what we were finding was that over 72, which we'll talk about later, 72% of patients actually came from more than 100 kilometers away. So that just the distance in and of itself, if you're talking about taking a bus for up to 1 to 2 days to get there is really prohibitive for families. And so again, the further away you were, the more likely you were to abandon treatment. It's too far, we can't do it. And so again, patients diagnosed too late, they're too far away. And so what we were really figuring out is how important it was to develop an improved network for earlier detection, quicker referral, and more care closer to where they are. And I think the other thing interesting too, and this is more on a social issue, there were a lot of taboos as far as cancer treatment. Families would abandon treatment, particularly, and what we found most often, this is actually from some of the work in Texas Children's Hospital, was that there were certain malignancies that families were more likely to abandon treatment. Most common being bone sarcomas, osteosarcomas, Ewing sarcomas. When the discussion of amputation came up, there were so many stigmas, cultural stigmas around that with the families, that they would end up just taking their child home often. It creates an amputation, limb removal creates a huge taboo on them, on the family. It interferes with their ability to be productive as far as laboring. And often families just were not able to cope with that as well. So again, how did we improve our outcomes from a socioeconomic standpoint? Well, we did. Our efforts were improving provision of chemotherapy through insurance. We had several projects where we were improving access to transportation, subsidizing transportation cost, both in Kenya and our time in Malawi, providing chemotherapy at free or subsidized cost, and really also improving supportive care pathology resources as well. So those were the kind of major lessons learned, and I'm scratching the surface. Those are some of the lessons learned from time in Kenya and Malawi, and I really want to look towards now thinking about, well, what does this mean for the doctor that is in rural Togo or in Papua New Guinea? How do we think about pediatric hematology oncology in the hospital mission setting? And again, some of the major issues, the treating facilities that are capable of doing pediatric oncology, they're too far away and patients get there too late. And if you look generally in most limited resources settings, most of the concentrations of PEDS-HEMONC resources are in one national or regional referral system. So it is a huge burden on families if you don't live close. You're prone to abandon treatment, and you're also prone to having too far advanced disease at presentation. So really, how is the mission hospital setting poised to help? Well, if I think about the mission hospitals, often they are located in places that are far away from the major metropolitan settings. That's not always the case, but particularly within the SP World Medical Network, you see a high concentration of hospitals and medical centers that are off the beaten path, at least from the main cities. And I'll take the example of Kenya. So if I look at these two stars being Eldoret in Western Kenya, Nairobi being in Central Kenya for our discussions. Eldoret, zooming in, Eldoret really covers the catchment of Western Northern Kenya. Nairobi covering central Kenya, and of course there's somewhere in the middle there's crossover. Some patients go to different spots depending on where they are. But both of these hospitals, these are the two major centers for pediatric cancer care. Both of these places cover a huge swath of geography and a huge patient population load. So if I think about how can you break that down to make it more accessible, I'm putting up two more stars. The one closest to Nairobi being Kajabe Hospital, which I had the privilege of recently visiting, as well as Tenwick Hospital, which is down in the southwest part of Kenya. So how do you, at least in this example, how do you potentially use these two mission hospitals, every country being different, every geography different, but at least thinking about this, how do you use these two places to improve access to care in conjunction with the larger treatment referral centers in Eldoret and Nairobi? So if I think about a tiered, what really comes to mind is kind of a tiered care system for pediatric hemonc, and really figuring out, given the mission hospital setting, given the resources, what can you do with pediatric hemonc, and how can you improve care, and at the very least, access to care? And so we start really with the low-hanging fruit of really seeing a mission hospital as being a care facilitator with the referral hospitals. These are in the situations where a pediatric cancer care unit or a hematology unit basically it's not feasible, it's not sustainable at the time. So what can you do to make that better? Because ultimately, in the mission setting, we have the privilege of caring for these families in Christ's name, and that's also consistent with getting them the care that they need, even if at times that's not within our own buildings. So what I think about, and what the discussions from with Tinwick and some of the other centers in sub-Saharan Africa have been figuring out the low-hanging fruit. I think number one, if you're in these rural settings and you're seeing children with PTMONC diseases, is number one, you have to find your referral hospitals. You have to find where they're treating patients, find the contacts, setting up an active line of communication with them, really to be able to refer them, to know what they're capable of treating, and know that they are capable of receiving these patients. Two, really stabilizing patients. They come in malnourished, they come in sick, and getting them to the referral center is not always, it's not a quick ambulance ride. So knowing that you're part of our calling is to get them stabilized, get them in a place where they can get to the hospital, but being cognizant really of the fact that not everyone referred actually makes it to the referral hospital. If I look in the case of Tinwick, so 25% of all Eldoret's patients come from the Tinwick, come from the area in Southwest Kenya that Tinwick serves. Now, unfortunately, though, when you compare the numbers that actually show up in the door in Eldoret versus the numbers that the pediatricians and the surgeons see in Tinwick, that number in Tinwick is much higher. Not all families actually make it to the referral hospital. There are a lot of fears. There are a lot of, even within countries, there are language barriers, cultural barriers that make it nearly insurmountable to families. So often they don't even get to the referral hospital for treatment. So being cognizant of the fact that if you're going to refer a patient, how do you set up those channels to make sure that they get to where they need to be? And then also patients that are being treated at the referral centers but live closer to the mission hospitals, what can you do during routine illnesses? What sort of care can you do when it would be impossible to transfer a patient? For example, a patient currently undergoing chemotherapy and is neutropenic and develops a fever. Well, we know through the literature that the risk of sepsis for a febrile neutropenic patient is high. And when you're talking about 6 to 8 hours to get to the referral center, the risk of dying en route is not zero. So are there situations where the mission hospitals can step in and provide those timely urgent care needs? And then also, especially given the fact that many of our supported mission hospitals have dedicated surgeons, is it possible to do diagnostic biopsies, get the pathology up to the referral centers quicker so that a diagnosis can be made? And then not only from the oncology side, but also from the hematologic side, really the low-hanging fruit. And this is for centers that are in sickle cell. And I'm touching on sickles. I'm talking about sickle cell, but obviously there's hemophilia, there's aplastic anemia, there's a lot of other hematologic issues that we're not addressing, but this is being the most common hematologic disorder that really limited resources settings are seeing. If you are in a sickle cell endemic area, it is absolutely entirely possible to set up care for sickle cell anemia, even from newborns being tested with point of care sickle cell tests now, and also affected children that the clinicians would suspect that they might have sickle cell disease. Initiating hydroxyurea, initiating antibiotic prophylaxis, chronic pain management, stroke prevention, and then also treatment for acute pain crises, vaso-occlusive episodes, and acute chest syndrome as well. So it is not sickle cell disease generally is easier to care for sickle cell disease is easier to provide for in these limited resource settings because it does not require the same degree of supportive care, the same degree of resources that cancer care inherently does. And then I think moving forward, positioning the mission hospitals into caring for these kids, moving towards more of a phase 2 hybrid shared care with the referral hospitals. Not all, if you think about setting up a collaboration with the primary treatment or referral site, it is possible for mission hospitals that are far away to do provide some limited chemotherapy care. There is a lot of low risk, or we would say maintenance chemotherapy that is teachable, and it's doable, and it's manageable, and it doesn't require the same amount of supportive care as during major induction treatment or more immunosuppressive chemotherapy. Part of that involves creating a shareable registry database with the referral sites to be able to know what patients are getting treated with what at the respective institutions. So that just comes through ongoing communications with the referral center. That goes just with developing that network. Also, what else can be done from an oncologic standpoint? Well, follow-up care for off-treatment patients, survivorship care. Also, as well, using the surgical teams at the mission hospital sites for local control. A good example right now at Tenwick, Eldoret's surgical team is so overbooked and so in need that they will actually send patients to Tenwick for Wilms tumor surgery. So really figuring out what are the resources that the mission hospitals can also provide in collaboration with the treating centers. And then I think finally, and most importantly, the reality is that more children than not at this point will die from malignancy in limited resource settings in sub-Saharan Africa. And so the foundation to any good oncology team, and really to an extent as well to a hematology team, is having a well-grounded palliative end-of-life care program. This is the area, I mean, for a family to be able to be either home or close to home to receive palliative end-of-life care, that is a lot more bearable than being eight hours away at a referral hospital. And it also, and speaking from the mission side, it is also another opportunity for those of us in the mission setting to pour Christ's love and mercy out to dying patients. And so I think that could be a great strength to the mission hospital setting for these patients that are not able to be successfully treated. And then finally, in developing an independent site care center for Peds Hem-Onc. And this is a process of years and not months. And a great example, Kijabe Hospital has, under the direction of Dr. Numa and Dr. Shirk, developed a oncology program there. It has been years in the making. There are still areas to grow and improve, but much of that depends on having good diagnostics, good pathology resources, being able to have good chemotherapy provision, and then most importantly, being able to continually teach, train clinicians and nursing on how to provide good oncology care as well. And in some places that is not appropriate. The resources aren't there. There are other priorities in those hospitals. But for some places that might be an appropriate long-range goal. And again, if I think about developing out of Tenwek, developing out of Kijabe treatment centers, you see that all of a sudden that the area of coverage for care and the accessibility of care greatly increases. I think this does speak to our desire to really meet families where they are, provide care, the best care possible, and I do believe that it is God honoring to be able to find ways of making treatment more accessible to them closer to where they are. And again, as a result, care is accessible, treatment's more possible. We have improved access for earlier diagnosis, less risk of treatment abandonment, and then where appropriate, setting up a national, regional shared network within the other hospitals in the country or the region. I think that does speak well when we're able, from the mission hospital standpoint, when we're able to care well for the children of a host country and work in conjunction with the hospitals, existing government hospitals there. I think that speaks to it's God honoring. I think that speaks well of the mission hospitals. It honestly speaks well of God's love for his people. So, and again, for those who are on the ground, my homework for you, if you will, is really start to think critically about where you are in the Peds Hem-Onc with regards to Peds Hem-Onc care. What is the low-hanging fruit that is obtainable, at least in the short term or medium term, given the current settings? What are the long-term possibilities? And finally, kind of as a pitch, how can we help? This is something that I have spent a good deal of time talking to Dr. Lance and Dr. Tom and the team at World Medical about how do we improve care for Peds Hem-Onc in the mission hospital setting. And so I would want to extend myself out as however I can be a help, encourager, consultant to where you are given your situation, given your hospital setting. I would love to. So this is my contact information if you want to take a screenshot of that. And please feel free to reach out to me. I am privileged to talk to all of you today. I am privileged to be able to serve in this capacity, and just prayerful that God would use our gifts, our desires to serve and honor him in all our works. So I think that's all I have. Let me get out of there.
All right. Well, Steve, I just want to thank you so much for a great presentation. Let me say how excited we are here at World Medical Mission to be working with you to really to push this topic forward and really just work with our partner hospitals to advance oncology care. As you've alluded to, there's a long way to go, and so it's really exciting to launch this initiative, to take some of these initial steps with our partner hospitals like Kajabi and Tenwick, and really extend services at places like Moy University Teaching Hospital in Eldoret. So I know you just recently came back from there, and as I've said prior to the presentation, I look forward to further conversation and as we work together to develop this network of oncology and hematology services. So with that, I'm just going to extend questions and answers to our listening audience. I don't believe that I have any at this point. So if you're a HEMONC person out there, I encourage you to pose questions to Dr. Martin. I'm a lowly internist, so I need your help.
Right.
But let me just say, as we're waiting for questions, Steve, again, it's very exciting, and I appreciate your invitation to our listening audience. We're really just taking initial steps. So if you're interested in working with us here, we're really excited to launch this initiative. What's exciting to me is as Steve so poignantly displayed at the beginning of his presentation, there's an incredible disparity between the management of HEMONC issues in the United States, with an approximate 80% survival rate versus 80% demise in sub-Saharan Africa. So there's a lot of work to be done. And so I really encourage you to reach out to Dr. Martin and work with us as we really want to advance this treatment. Let me start off with Dr. Martin, a good friend of mine. He is my former CEO. Chris Host says, it would seem that some of the infrastructure and logistical issues with PED HEMONC faces are issues for other clinical services as well. Did any of the areas you worked try a multi-specialty approach? That's a good question.
No, that's great. Thank you for the question. I think one thing when we talk about PED HEMONC, our team in Texas would always say it's the tide that rises all boats. And I say that because PED HEMONC is so dependent on other clinical services. It is dependent on radiology. It's dependent on pathology. It's dependent on a functioning blood bank. It's dependent on a good pharmacy. And so it really is, there's so many other areas that there's no way I can do my job without. It's a humbling place to be a part of that, be a part of the body and realize how much you need each other as an oncologist. I think that has been one of the things that at least our time in Kenya and our time in Malawi has been as well, is building up those other pieces of the puzzle as well, to improve the blood bank, improve chemotherapy. It spills into better critical care for pediatric patients. It spills into better chemotherapy provision for adult patients. It spills into overall better pathology resources. So I think my hope is that in doing this with PED HEMONC, that actually expands the improvement of care in other areas. So I think it inherently is touches other specialties. And really, if I think about one of the backbones of developing pediatric hemo care, is nursing. Nursing is vital to care delivery. It is that was probably the biggest push for us as far as nursing teaching and training, and really expanding the capacities of the nurses that we worked with in those settings. Traditionally, nurses were not given were given very limited delineated roles in settings like where we were, and to be able to push them, give them further opportunities and kind of expand their capabilities, that was probably where we saw a lot of traction and development in care. So there's a lot in doing that, I guess, in going to say in developing pediatric oncology treatment. It touches much more than just peds hemo.
Right.
So I hope that answers the question.
Yeah, that's a great question, and you're exactly right. I think it really does raise the level of responsibility of the other disciplines to provide excellence in care. Yeah, I'm glad you mentioned nurses. My sister is an oncology nurse, and she would be glad to hear us advocate for their excellence in work, their clinical work, because without excellent, clinical nursing, we certainly couldn't provide great oncology care. One other thing, Steve, we haven't mentioned, but maybe just want to mention briefly, maybe in conjunction with this, we've certainly looked at development of telemedicine too, perhaps to assist in diagnostics and radiology, pathology. It is a multidisciplinary approach, and hopefully as we move along, we can incorporate this technology of telemedicine to provide other services in the effort.
Yes.
Steve, a similar question. It says, how did you manage the problem of allocating and maintaining the support, and maintaining the supply of chemotherapeutic agents logistically in low and middle income countries when allocating treatment to patients?
Okay. Yeah, that's a great question. And I'll be the first to say is we didn't do it perfectly. That was very hard. We had gone, if I think about methotrexate being one of our staple chemotherapy drugs for leukemias, Wilms tumors, Burkitt's lymphomas, we had a time in Malawi where we probably went 3 months without it. And that was hard. We had to make adjustments to treatment protocols because we were able to do work with what we had at the time. How that improved for us, honestly, our nurses, they took the initiative of developing, looking at our we had gone through our monthly stocks, figured out how much chemotherapy in a month, in a quarter, and then being able to anticipate ahead of time, hey, this is probably what we're going to need to take care of these patients well in advance. So we don't have stockouts. We're not going months without missed chemotherapy. And I think one of the questions is too, is really taking a hard look at the feasibility of what and when to give chemotherapy. Many times we had patients, I'll admittedly say we treated patients with relapsed neuroblastoma, relapsed AML that would have been very, very difficult to treat in the US, but that did use a lot of chemotherapy, that did use a lot of blood products, and in the end, it was the outcomes did not change, and so really thinking judiciously about if I'm going to give a patient chemotherapy, are we going to be reasonably hopeful that this would get them into remission? And unfortunately, those are hard conversations that you have to have in these places and situations. But but those were kind of the challenges of what we dealt with as far as access to medicines.
All right. Well, thank you, Dr. Martin. Phil Ferguson says, we are working on launching digital imaging and immunohistochemistry in the pathology lab at Kajabi Hospital in the coming months. Dr. Martin, can you discuss pathology access from your experiences?
No, that is, and that's one of the problems, and particularly thinking about Kajabi and Tinwick as well. The pathology turnaround time is long. And if I think about Tinwick in particular, with Dr. Clark Sleeth, the turnaround time was up to 4 weeks. They would do a biopsy, they would send a bone marrow sample for a suspected leukemia patient to Nairobi and would not get pathology back for a month's time. That's a critical month when you think about a child that's presented already in advanced disease and already malnourished. And so that puts you even further back in your ability to successfully treat them. So pathology access to timely, accurate pathology is really one of the key things that we want to look at with Tinwick, that we want to look at in the other mission hospital settings. That can be done in a variety of ways. That can be done through a partnership with the referral hospital, if you can figure out how to get the pathology there quickly and the turnaround quickly. But also talking about, going back to what you were talking about with telepathology, teleradiology, there are ways to set that up to where clinicians can get a diagnosis quicker than 4 weeks time. And I think if we can do that better, then we're going to be able to provide better care for these patients.
Excellent. All right. Well, thank you. Yeah, I look forward to observing as that process occurs and we see earlier diagnoses through these technologies. Dr. Sam Williams says, what are some specific ways that you can or that you've seen work well to build up a malnourished child as soon as possible before they begin induction treatment for cancer?
Yeah, so often patients, when they presented, they were, we knew they were too sick to withstand induction chemotherapy. So our approach in Malawi in particular was to try to get them, number one, get them stabilized. We would start them on RUTF, ready to use therapeutic food. I think it's plumpy nut in some places. But we would get them on meat, have them meet with nutrition, get them on an aggressive feeding regimen, and try to get their nutrition stores up. At the same time, then you have to go back. Again, what I was talking about earlier is treatment protocols in high-income settings are not directly applicable to low-income settings. So what we ended up doing in many cases is giving low-dose chemotherapy to keep the cancer just at bay enough to where we could get these kids a little better nourished, a little less distressed, and a little more prepped for chemotherapy. And then we would push them through. We would push through with aggressive nutrition through treatment as much as possible.
All right. All right, Dr. Martin, I don't see any additional questions at this point.
Okay.
Again, yeah, thank you so much for being with us today. Again, look forward to talking to you offline further about our initiatives with hematology, oncology care in the developing world setting. Just want to remind our listening audience today that CME credit, as usual, is available for this session. The form and instructions are going to be sent on to you in an email, and we'll have a recording sent out to you as soon as possible. If you haven't, we encourage you to join the forum at health.samaritanspurse.org, and you can learn about the next webinar series, and also just encourage you to access our archives available at that website. Next month, Dr. Sam Williams is going to be speaking to us about his clinical experience in over 30 years of volunteerism at World Medical Mission. So we're really excited to have him speak to us at Wednesday, October the 13th, 12 noon Eastern Standard Time. And with that, we'll conclude. Thank you so much for joining us today. God bless. Take care.